Hello everyone. Welcome to this presentation on Labetalol, a versatile agent in cardiovascular therapeutics. I am Docsaab and today we will explore Labetalol's pharmacology, clinical applications, and practical considerations. By the end of this talk, you will appreciate its unique profile and when to reach for it in your practice. Let's dive in. Starting with the basics, labetalol is a non-selective beta blocker with additional alpha-1 adrenergic blocking activity. Chemically, it is a benzothiazide derivative available in oral and intravenous forms. Its mechanism is what sets it apart. Non-selective beta blockade, beta 1 and beta 2 reduces heart rate and contractility, while alpha 1 blockade causes vasodilation, lowering peripheral resistance. The ratio is about 1 is to 3 for IV, alpha is to beta, and 1 is to 7 for oral, minimizing beta mediated side effects like bronchospasm. Think of it as a balance blocker. Alpha action prevents the blood pressure spike from unopposed alpha stimulation during beta blockade. Pharmacologically, it is unique because it doesn't cross the blood-brain barrier much, reducing CNS side effects compared to lipophilic beta blockers like propranolol. Historically, labetalol was developed in the 1970s by Allen and Henbris as an improvement over single receptor agents, gaining FDA approval in 1976 for hypertension. It's been a staple in emergency settings ever since. Moving to pharmacodynamics, labetalol's receptor specificity targets alpha 1 postsynaptic receptors for vasodilation and both beta 1 and beta 2 for sympatholysis. Its potency is moderate. IV doses achieve 25 to 50% reduction in mean arterial pressure without severe hypotension. Clinically, it decreases heart rate by 10 to 15 beats per minute, lowers systolic diastolic BP by 20 to 30 mm mercury, and maintains cardiac output better than pure beta blockers due to reduced afterload. This makes it ideal for patients with preserved ejection fraction. Pharmacokinetically, oral absorption is 25% bioavailability due to first pass metabolism with peak effects in 1 to 2 hours. It's highly protein bound, distributes widely, and metabolizes hepatically via glucuronidation, no active metabolites. Excretion is 50% renal, 50% fecal, so dose adjustment in severe liver disease. Onset is rapid, IV 5 minutes, lasting 2 to 4 hours, oral 30 to 120 minutes, up to 8 to 12 hours. Half-life is 6 hours, but effects linger due to receptor binding. In renal impairment, no adjustment needed, unlike some really clear agents. Labetalol signs in clinical use. For hypertensive emergencies, think BP more than 180 by 120 with organ damage. IV labetalol is first line, titrated every 10 minutes to reduce mean arterial pressure by 25% in the first hour per GNC guidelines. It is preferred over nitroprusside for its ease and lower toxicity risk. In chronic hypertension, oral labetalol is effective for essential hypertension, especially in younger patients or those with tachycardia. A standout indication, hypertension in pregnancy, category C but extensively studied. It is the go-to for preeclampsia and eclampsia, crossing the placenta minimally and not causing fetal bradycardia like pure beta blockers. ACOG recommends IV 20 mg bolus, then infusion at 1 to 2 mg per minute. Post-MI, it reduces reinfarction risk by blunting sympathetic drive. For pheochromocytoma, preoperative alpha blockade with labetalol controls BP surge during tumor manipulation, combining alpha-beta effects safely. Dosing is straightforward but requires monitoring. For oral therapy in chronic hypertension, initiate at 100 to 200 mg twice daily, titrating upward by 100 to 200 mg every 2 to 3 days to a maximum of 2400 mg per day, guided by home BP charting. BID dosing leverages its 8 to 12 hour duration, improving adherence over TID agents. In acute IV settings like the ER for crisis, 10 to 20 mg bolus over 2 minutes, dilute in NS, repeatable every 10 minutes up to 300 mg total, or continuous infusion at 0.5 to 2 mg per minute, maximum 300 mg per 24 hour. In pregnancy, use conservative boluses 10 mg to mitigate fetal effects per ACOG protocols. Titration strategies, always monitor continuously. Heart rate should stay more than 55 to 60 beats per minute to avoid bradycardia. BP every 5 minutes initially, aiming for 20 to 25% mean arterial pressure reduction over 1 to 2 hours. Use non-invasive cuff or arterial line in ICU. Watch for orthostasis post-dose. Parameters include ECG for conduction changes and labs for electrolytes as hypokalemia exacerbates arrhythmias. For special populations, renal impairment, even dialysis patient requires no adjustment, as less than 5% is renally excreted unchanged, ideal for CKD comorbid hypertension. In hepatic impairment, half the dose in childhood B and C, such as start at 50 to 100 mg oral to prolong half-life. Monitor LFTs monthly. Pediatrics 1 to 3 mg per kg per day oral divided TID. Elderly or volume depleted start low as 50 mg oral or 5 mg IV to prevent hypotension. Always pre-medicate with fluids if dehydrated and avoid in acute decompensated heart failure. While generally well tolerated, labetalol has a predictive side effect profile. Common ones affect 5 to 20% of users: dizziness or lightheadedness from postural hypotension, fatigue or somnolence, nausea or GI upset. A quirky but benign effect is scalp paresthesia or tingling, reported in 5% due to alpha 1 blockade in dermal vessels. Reassure patients it's not serious. Serious adverse events are less frequent but critical: bradycardia, bronchospasm, or wheezing in susceptible asthmatics, heart block or AV conduction delays in pre-existing bundle branch disease, rare but notable hepatotoxicity, masking of hypoglycemia symptoms in diabetics, or drug-induced lupus. Post-marketing reports include severe hypotension in overdose managed with glucagon or pacing. Drug interaction, synergistic hypotension with other antihypertensives, enhanced bradycardia with calcium channel blockers like verapamil, increased levels with CYP2D6 inhibitors like cimetidine or fluoxetine, NSAIDs blunt antihypertensive effect via prostaglandin inhibition, caution with alpha agonist like clonidine that causes withdrawal hypertension. Contraindication, absolute contraindication include second and third degree AV block without pacemaker, cardiogenic shock, severe bradycardia, or decompensated systolic heart failure. Relative contraindication include reactive airway disease such as asthma and COPD, peripheral arterial disease, uncontrolled diabetes, or Raynaud's. In pregnancy, it is preferred but weigh against alternatives if fetal distress suspected. Special consideration elevate labetalol's utility. In pregnancy, its safety is robust. A 2019 meta-analysis in hypertension shows superior BP control versus nifedipine with 10% lower risk of severe maternal hypertension and no increase in perinatal mortality or NICU admissions. Efficacy stems from rapid titration and hemodynamic stability. Fetal monitoring is a key during IV use. Comparison highlight its niche versus pure beta blockers like metoprolol. Labetalol avoids reflex hypertension versus alpha blockers like doxazosin. It better controls heart rate without orthostasis alone versus direct vasodilators like hydralazine. Smoother onset without headache or lupus risk. In diverse population, EHA 2017 guidelines favor it for black patients with hypertension due to efficacy in low renin states and its cost effective. Monitoring orthostatic hypotension is essential. Check supine standing BP 4 hourly initially as alpha effects peaks 1 to 2 hours post-dose. In elderly or dehydrated patients, prehydrate with 500 ml NS to buffer drops more than 20 mm mercury systolic. Patient education, counsel on consistent BD dosing with meals for optimal absorption, warn of dizziness, rise slowly, avoid driving if affected, emphasize no abrupt suggestion, limit alcohol and report symptoms like fatigue or wheezing. For diabetics, monitor glucose closely. In presentation, stress decision making, discuss lifestyle first, then meds as adjunct. In summary, labetalol is a dual alpha beta blocker with unique advantages: rapid onset, balanced hemodynamics, and versatility across hypertensive scenarios from emergencies to pregnancy. Its profile minimizes common beta blocker pitfalls, making it to go to in family medicine and beyond. Key takeaways: prioritize in acute hypertension and preeclampsia, monitor heart rate BP closely, remember its hepatic metabolism for special populations. Thank you guys for your attention. I love to hear your thoughts or questions. Feel free to DM me via Instagram or comments. And please like, share, and subscribe to the Docsaab's Diary.